taking a look at the integumentary system, otherwise known as the skin. This is going to be the first system that's going to utilize all four different types of tissues: epithelial, connective, muscle, and nervous. The organs included in the integumentary system will include the skin, which will be made up of epithelial and connective tissue, as well as the accessory structures, including hair, nails, and glands. Nerve cells are represented by sensory receptors for pain, hot, cold, pressure, and also itch, which is not listed here. And finally, we'll see smooth muscle, which will be located in the dermis, attached to the hair follicles. These will be involuntary muscular contractions. Functions of the integumentary system include maintaining the body's integrity. So very simply, just a barrier between the inside environment of the body versus the outside environment. Also helps prevent any kind of major damage from either certain types of foreign substances or possibly foreign organisms. Also helps maintain temperature. Very simply, the adipose layer or the fat layer found in the subcutaneous layer is used as an insulator to keep body heat in. And of course, as we know, we want to keep temperature within a certain range, so proteins can stay active and or prevent them from denaturing into inactive form. Also, within the skin layer, it will convert inactive vitamin D found in the dermal layer on its way to become more enzymatically active as it passes through to the liver and finally to the kidneys. Also, the integumentary system is going to be a huge bank of sensory receptors to give us information from the outside environment, whether it be from temperature, whether it be from pain, itch, pressure, you name it. And also, it'll help maintain homeostasis, which we'll get into a little more thoroughly in the next slide. As we look on the focus on homeostasis, we can see that pretty much every system is going to be interdependent with the other systems of the body. If one system fails, then in a very cascade-like fashion, other systems will fail as well. So very simply, for the integumentary system, as we know for all the body systems, it does provide a barrier to help protect the internal organs. It also works to help maintain temperature by using the sweat glands and also to either dilate or constrict blood vessels in response to certain types of temperatures. But also we see different types of glands found within the skin to keep it healthy and keep it supple so it doesn't dry out or become too oily. And very simply will act as a barrier for the lymphatic system in particular to fight against microbes. It'll work with the skeletal system and the muscular system to provide vitamin D, as well as calcium ions for proper bone structure and for proper contraction. As we mentioned before, for the nervous system and reproductive systems, we use the nerve endings found within the integumentary system layer to basically give us information on the outside environment. And of course, that's very important for the reproductive systems to basically engage other systems to prepare for either intercourse or for other things related to the reproductive system. We look at the cardiovascular system, where basically local chemical changes in the dermis will basically influence how well the blood vessels will either dilate or constrict. And of course, that also ties into the respiratory system as well. The digestive system is going to be dependent on the vitamin D to basically allow proper absorption of dietary supplements, which we'll get into a little more thoroughly when we talked about your calcium supplement question in last week's lecture. Now, as we look at the skin in particular, the skin is going to be comprised of three layers. Very simply, the outer is going to be called the epidermis, so it's going to be the most apical layer. Next, you'll find the inner, or the sandwich layer of the dermis, and finally you have the hypodermis, more well known as the subcutaneous layer, or the subcu layer found within just underneath the dermis itself. The epidermis is going to be made of epithelial tissue, whereas the dermis will be connective tissue, and the subcutaneous is going to be made of connective tissue and primarily adipose tissue and blood vessels. In every chapter, I always mention that there's one slide that is probably most important out of all the other slides I'll present to you. For the Chapter 5 Integumentary System, this is it. Very simply, this gives you a very nice overview of the entire portion of the skin itself. So very simply, you can see off to the right, you can see the epidermis here. You're going to see the dermis layer found just underneath the epidermis, and then finally, deeper than that, you find the subcutaneous layer as well. So very simply, going into the epidermis, you're going to find two things off to the left here. One will be the epidermal ridges. This is very important for the structure of your fingerprints and toe prints. You'll see that it looks very jagged when it comes up against the dermal papillae, which is going to be in the dermal layer itself. This jagged or jigsaw-like appearance helps provide strength between the epidermis and the dermis to prevent any kind of tearing of the two layers in between. Now, found within the epidermis itself, you can find the hair shaft, You're going to find pores for the sweat glands in particular. We get into the dermis, you're going to find a myriad of different structures here. First, we can look at the hair itself. The shaft will basically go into the dermis and go into the hair follicle, followed by the hair root. You can see just off to the side of the hair follicle and root, you'll see the rectus pili muscle. This is smooth muscle, gives us the goosebumps. You also see embedded in the dermis as well, you're going to see both arteries and veins, which help draw blood back and forth in through the dermal layer. You'll also find embedded within the dermal layer a bunch of different nerve endings, which we'll get into a little more thoroughly, both in this chapter and also we get into the peripheral nervous system. But you'll find different types of corpuscles, like you see a laminated or Pacinian corpuscle. You look at it a little more closely, it looks like the structure of an onion. You'll find other types of free nerve endings from very close to the basal layer where the epidermis and dermis meet. You also find areas there for cold and for heat sensations as well. And finally get down into the subcutaneous layer. I'm sorry, I missed two sweat glands. You'll find eccrine and apocrine sweat glands. We'll talk about where you find those primarily along the skin layer. Those actually will help basically dissipate any kind of body heat through the evaporation of sweat and water. You'll find the subcutaneous layer on the bottom there, which is primarily made of adipose tissue. So this is your insulation layer that helps maintain body heat. Now, specialists for skin disorders include dermatologists. Very simply, you'll see here one of the common things that they treat are different types of burns, which we'll get into a little later on in the chapter. They'll also take care of different types of warts. They'll take care of any kind of dryness of the skin, psoriasis, as well as cancers, which we'll get into a little later on as well, different types of cancers. Hopefully none of you have been subjected to this kind of thing, but again, dermatologists are the doctor of choice to see for any kind of skin disorder. Within the epidermis, you will find different types of epithelial cells. You'll find keratinocytes, which will secrete the protein keratin, which is a waterproofing protein, as well as a protective protein. You'll find melanocytes, which will secrete melanin to basically protect the nucleus and nuclear material from UV light. You'll find intraepidermal macrophages, which sounds exactly what it is. These are white blood cells that will basically move through the tight spaces between the epithelial cells to basically absorb any kind of foreign substances and or microbes. And finally, you have tactile epithelial cells. You notice this is going to be made up of two different types of cells. You'll find a sensory neuron, which will be embedded in the dermis, whereas the tactile, or is known as a Merkel disc, for senses of touch, will be found in the basal layer, which we'll get to in a few moments. So again, keratinocytes will produce keratin. It's going to be a fibrous protein that provides protection and waterproofing. Melanocytes will produce melanin. Your intraepidermal macrophages are involved in the immune response, and of course, tactile epithelial cells will be used for sensation of touch. In most layers of epidermis, you'll have 4 layers of skin. In thick skin, which we found in the palm surface of the hand, as well as the plantar surface of the foot, they'll have thick skin of 5 layers. So very simply, from deep to superficial, you have the stratum basale, the stratum spinosum, stratum granulosum, the stratum lucidum found only in thick skin, so again, only in the palmar surface of the hands as well as the plantar surface of the feet, and then finally the most superficial, the stratum corneum. So here we see a representation of the 5 layers of the epidermis, as well as a portion of the dermis on the left. On the right is going to be a light microscope slide, which those of you who will be in lab will be looking at these a little more closely, both human and also frog epithelial cells. Some of the frog epithelial cells, the layers are a little more apparent. So very simply, of the 5 layers, again, if we're going from the deepest to most superficial, the first layer of highly mitotic dividing slides is the stratum basale, which these are cuboidal epithelial cells. Very simply, this forms the base layer as attaches to the basement membrane and also to the dermis. Next, you have the stratum spinosum. These will be the fully mature epithelial cells. Next, you have the stratum granulosum, where very simply you see them start to flatten and they start to have secrete more of the keratin. You see the lamellar granules there on the right-hand side. This is where you're going to see the epithelial cells start to harden. And then in only thick skin, as you see the stratum lucidum, notice that there is no nucleus found in those particular cells. At this point, the cells are dead. The stratum lucidum, they are fully keratinized or fully hardened. and then they'll also fill into the stratum corneum, which is going to be the most superficial layer. These are all dead layers of cells as well. This can be multiple layers thick, depending on how thick the skin is. In some areas, again, like in the plantar surface of the foot, also the palm of the hand, it can be very thick, whereas especially in the cheek area, they can be relatively on the thin side. So again, going from deep to superficial, it's good to know the different types of characteristics. Again, stratum basale is going to be highly mitotic. Dividing layer is going to be a single layer of cuboidal epithelial cells attached to the basement membrane, followed by stratum spinosum, where fully mature keratinocytes will be found. Stratum granulosum is where you can find highly keratinized cells, but they're still to be termed alive. Stratum lucidum is going to be found in thick skin only. This is where the cells sort of die off and nucleus no longer remains. And finally, the stratum corneum, these are all dead keratinocytes. Now you can kind of see interspaced in the stratum spinosum layer, the intraepidermal macrophage cell. Again, these will sneak by the tight junctions between the epithelial cells, and also you can see the tactile or the Merkel disc right at the basement membrane layer, as well as the tactile disc found within the dermal layer. And also you can see one melanocyte in particular very close to the basal layer there. Sometimes they can be sandwiched between the spinosum and the basale layers. So two types of skin that we see thin or hairy skin that covers all the body regions except for the palms and also the palmar surfaces of the digits, as well as the soles of the feet or the plantar surface of the foot. Thick or hairless skin covers the palms, the palmar surface of the digits, and the soles of the feet, of course. As I mentioned before, skin pigments, so we're going to find melanin, which will be more apparent in some and less apparent in others. Those with darker skin simply have either more cells or have more cells that generate more melanin, versus people that are more fair-skinned either will have very little melanin be produced or very few melanocytes. There are some types of disorders that we'll look at in particular, such as albinism, which shows either destruction of the melanocytes or simply the inability to produce melanin. So albinism is going to be a congenital disorder characterized by either complete or partial absence of the pigment in the skin, hair, and eyes due to a defect of an enzyme involved in production of melanin, or it could be complete destruction or not any kind of production whatsoever of melanocytes. So this is not in your textbook. This is something I pulled from the web. Very simply, this is a young boy who is an albino. You can see very simply that there is no pigment found in the skin, the hair, and also in the eyes. Now, the eyes can often be very pale blue because there's very little melanin found within the iris of the eye. Sometimes, if the albinism is very severe, the eyes can actually be pink, where very simply the blood vessels can be seen right at the iris of the eyes. So unfortunately, as you can imagine, those people with fair skin we know need quite a bit of sunscreen protection. People with albinism are very high susceptible to UV rays. Also, with different types of eye disorders, because of any kind of ultraviolet light, it can hit the retinal layer. It can also destroy a lot of the nerve cells found therein. So vision deficiencies are very common with people with albinism. Now, another type of skin disorder very similar to albinism, but with a very distinct difference, is vitiligo. This is a chronic disorder which causes depigmentation of only certain patches in the skin. It's not entirely known exactly why this occurs, but currently the research shows it could be a combination of genetic factors as well as some type of autoimmune disorder. Very simply, the melanocytes are simply destroyed or simply just don't produce enough melanin. But again, the main difference between this and albinism is going to be the entire body, whereas vitiligo will only be certain patches of the skin. So these are often termed cafe au lait spots, which basically means coffee with milk. So you'll see some will be significantly lighter versus the general area's pigmentation. You see the cafe au lait spots here on the individual patients on the upper left and upper right. So you can see the change in pigmentation from the normal patches of skin versus the depigmented areas of skin with cafe au lait spots. The picture on the bottom portion here is going to be under UV light. So just like with albinism, these people have to be very careful with the depigmented patches of skin. So oftentimes they'll wear some kind of covering and or some kind of sunscreen as well to help protect those bigger areas due to the lack of melanin. Next we come to the dermis, the second layer of the skin. which is going to be composed of connective tissue. So this is going to contain both collagen and elastic fibers. So the collagen is going to give the inherent strength of the skin layers. The elastic fibers allow it to stretch. So if you were to stretch your skin, very simply, it's elastic enough where it'll go back to its original shape, which we'll talk about later on. As we age, we start to lose that elasticity, or even under certain types of conditions like severe dehydration. You'll notice that the elasticity of the skin falters quite a bit. Now, out of the dermis, there's going to be two different regions. We'll find the papillary region, which is going to be lying just below the epidermis. It's where the two layers will attach to each other. And next you'll find the reticular region was going to be composed of dense, irregular connective tissue. We want it to be dense to provide protection, but also irregular because you want the collagen and elastic fibers to be interspersed in multiple different directions. So depending on the stress we put on the skin, it can take that kind of stress and reform back to its original shape. Next we have the subcutaneous layer, also known as the subcu or the hypodermis. This is going to attach the skin to the underlying tissues and organs. And again, as I mentioned before, this is where all the adipose tissue will be found as well, which will provide us with insulation as well as an energy store as well. As for the sensory receptors, I just asked to be able to identify where you find these in the particular skin layers. You'll find these all in the dermal layers. You're going to find the superficial types are going to be found more so closer to the papillary layer, whereas you're going to find the more deep in the reticular layer in particular. So superficially, you're going to find what's called type 1 cutaneous mechanoreceptors. Slow adapting very simply means that when you have any kind of pressure on the skin, as long as pressure is still there, you'll still perceive it. Whereas there's other types called fast adapting, which we'll talk about when we get into the nervous system chapter. Those are types of things when you first put on a shirt in the morning, you feel the shirt, but after the first 5 or 10 minutes, your brain kind of doesn't perceive it anymore. It kind of forgets it, so to speak, unless you go to shift and you feel the shirt a little bit more. So what winds up happening is with slow adapting, if the stimulus is still there, no matter what strength, it'll still fire off, you'll still perceive it. So imagine someone grabbing your hand. If they hold that grip, those are type 1 cutaneous mechanoreceptors that are adapting to that particular stimulus. Other types of mechanoreceptors that are fast adapting, these are types that if the stimulus did not change after a while, you don't perceive it, or again, the brain kind of puts it in the periphery and doesn't really perceive it quite as much. This also includes free nerve endings, which is going to be for pain, also for heat and also for cold. You'll find the corpuscles of touch. This is both for fine touch and also for deep touch, and also the hair root plexus. So these will be, in particular, if you feel breeze across your skin, these hair root plexuses will detect that. Or if you have anything that may be crawling on your arm, again, those hair root plexuses will detect that type of movement. As far as the deep sensory receptors, you're going to find what's called the laminated corpuscles, otherwise known as Pacinian corpuscles. It is more like vibration sense. Again, we'll get into these more so in the nervous system chapter, but I just ask that you know where you find receptors found in the superficial layer versus deep layer. So again, superficial would be the papillary layer, and the deep will be more in the reticular layer. So looking at the slide again, you can see the sensory neuron and the tactile disc will be found in the dermal layer, and you found the tactile epithelial cell found in the epidermis. So these are representative of most of your free nerve endings, as well as some of your corpuscles of touch, as well as some of your mechanoreceptors that help detect either fine touch or any kind of rough, deep touch. We'll find 3 different types of accessory structures of the skin. We'll look at hair, we'll look at nails, and we'll look at different types of glands. We'll find hair in all surfaces of the skin except for the palms, anterior surface of the fingers, and also the plantar surface of the feet. It's going to be comprised of dead keratinized epidermal cells, very similar to the stratum corneum, but we'll look at some very vital differences in the next few slides. It is your genetics that's going to determine your thickness, the pigment, also distribution. 2 main functions include protecting the scalp from UV rays and also prevent heat loss as escapes from the head. Other hair found throughout the body, depending on their location, can also have different functions, including working the way cilia does in the lungs. It works to trap or filter certain types of particles. So therefore, your eyelashes and eyebrows work to filter any kind of foreign substance away from the eyes. Your nose will help protect the internal workings of the nasal passage. And of course, the ear will help protect the ear canal by having different types of hair to trap particles through there in combination with your earwax. Also, there are touch receptors found on the hair follicles, as I mentioned before. So again, protection of a breeze blowing across the skin, or possibly detection of bugs possibly crawling across your hair there as well. The part that is going to poke through the skin surface is known as the shaft. Anything found below the surface of the skin is known as the follicle. We'll look at these a little more closely when we get into the lab, look at the lab slides. The root is going to penetrate into the dermis, including the epidermal epithelial root sheath as well as the dermal root sheath. A close look at the hair shows the hair shaft poking through the epidermal layer. Found deep within the epidermal layer, you find the follicle as it goes underneath the layer of the skin, and they come down to the hair root. Now notice too, you also see sweat glands going to be attached to hair root as it goes through the epidermal layer. The epidermal sweat gland is going to help nourish and bathe the hair with different types of oils to keep the hair supple so it doesn't dry out. As you venture deeper into the dermis, you're going to find the hair root plexus. That's what's going to detect any kind of motion from the hair shaft from an outside stimulus. The bulb, as you see, is going to include all the mitocondrially dividing epithelial cells that's going to generate the hair in particular. The papilla of the hair you're going to see is where you're going to have a little loop or a capillary loop where fresh blood and nutrients will come through and it'll take away the waste back through the venous system. You'll see the rector pili muscle, which again is going to be smooth muscle, so it's going to be involuntary. This is what causes the goosebump of the particular hair, have it stand straight on end. You see it attached right to the bulb of the hair itself. Here we're going to take a closer look of the bulb of the actual hair itself. If you look at the most inferior portion or deepest portion of the bulb, you'll notice blood vessels that are going to be intertwined into the papilla of the hair, which is going to form a meshwork or a capillary bed that'll help feed and nourish the melanocytes and the hair matrix, which is going to be the basal layer of the actual hair itself. The hair matrix is going to be very reminiscent of the stratum basale found in the epidermis in particular. Now, for most people, you're going to find 3 different layers of the actual hair itself: the medulla, the cortex, and the cuticle of the hair. In some people with thin hair, you may not find a medulla in particular. So very simply, the hair matrix will mitocondrially divide and push new cells up towards the epidermal layer and starts deaden as they get closer and closer to the epidermis itself. If you notice, there's 2 types of root sheaths here. You find the epithelial and the dermal root sheath. The epithelial root sheath is going to be both external and internal. This is going to be a continuation of the epithelial or epidermal layer. We notice the dermal root sheath is going to be continuous with the dermal layer. As you can see, the same root sheaths will actually start to dispel a bit as you get out towards the most superficial part of the hair itself. But again, you still see in the hair root in particular, you see the medulla, the cortex, and also the cuticle of the hair. That's the actual hair itself, and it goes, again, it's going to travel through the epidermal and the dermal root sheath. Again, the epithelial root sheath is going to be continuation of the epidermis, whereas the dermal root sheath will be continuation of the dermis. In terms of hair growth, we generally see 3 different stages. We see the growth stage, we see the regression stage, as well as the resting stage. So the growth stage means exactly what it says it means. Very simply, the hair matrix will continue to mitocondrially divide and push more cells and basically grow the hair as it moves through the epidermal sheath out to the epidermis and as a shaft of the actual hair. This will last anywhere from about 2 to 6 years. Then it'll hit what's known as the regression stage, where very simply the hair matrix will stop mitocondrially dividing, the follicle will start to shrink, and this may last a few weeks, sometimes 2 or 3 weeks, give or take. And then finally go into what's called the resting stage, where basically the hair matrix will start to replenish itself and very simply prepare itself for the growth stage again. This can last up to 2 or 3 months. When there's a disruption in these types of stages, we see different types of hair disorders. In this case, we see hair loss, also known as alopecia. Different types of alopecia I want you to be aware of is alopecia areata, which is what's known as spot baldness. This is usually stress-induced. It can happen to men and women equally. Sometimes it can also happen with chemotherapy. The other type of hair loss we often see is androgenic alopecia, or what's known as male pattern baldness. This usually starts at the crown of the head and then starts to work its way towards the frontal area as well as the temporal area. Those are 2 of the main types of male pattern baldness, although you can get complete hair loss from male pattern baldness as well. For some, it can be as early as their early 20s, or some people may not lose their hair deep into their 70s or 80s. Next, we'll talk about different types of glands. We find 4 different types of glands found within the skin. First will be the sebaceous or the oil glands. This will be connected to hair follicles. The oil glands will form what's called sebum, which will include different types of inorganic salts, as well as different types of oils to help nourish the hair and to prevent any kind of brittleness. Next, we find 2 different types of sweat glands. We find both eccrine and apocrine. The eccrine are what we found are the most numerous. We'll be checking how well these work in labs sometime later on this week. These you find on the arms, you find on the legs, you find different areas of the body. Next, you find more specialized sweat glands known as apocrine sweat glands. These are going to be found in hairy skin, so in this case in the groin area as well as the armpit area. Very simply, what winds up happening is these secretions will often react with bacteria, and this will oftentimes create a very particular kind of odor. The last type of glands we'll see associated with skin are the ceruminous glands. These are going to be modified sweat glands, that are going to be located within the ear canal, which will also help, again, nourish and protect the ear canal itself. Occasionally, we see different types of disorders with sebaceous glands, in this case, acne, where very simply there'll be inflammation in the sebaceous glands, usually inflamed during the puberty stage. Bacteria will feed on the sebum itself. If left untreated, it can cause scarring in the connective tissue called cystic acne, which I may have mentioned to you before. With scarring, it's a very random type of tissue. It's filler tissue, otherwise known as connective tissue as well. It's very dense and very irregular. Usually we'll need to see a dermatologist to help treat this. I think the latest treatment now is to use lasers to try and break up some of the scar tissue and then allow the healthy tissue to basically mitocondrially divide and fill in the damaged areas. And finally, nails will be the last accessory structure of the skin. These are made from keratinized epidermal cells. The structures of the nail will include the free edge, which is the most distal whitish portion of the nail plate or the nail body. In some patients, you'll find the lunula, which is the whitest portion, which is the thickest portion of the nail plate. Some people, the lunula is very apparent. Some people, it will be very thin, if there at all. You find these on the fingers as well as the toes. Next, we have the eponychium, which is otherwise known as the cuticle. And finally, we have the nail root, which is going to be embedded in the folded skin underneath the cuticle, because we're going to find the nail matrix, where you're going to have the mitocondrially dividing cells. In the next slide, we'll look at a sagittal section of the nail itself. So again, this is another important slide here. You'll probably see this quite a few times, both in quizzes and also exams. So if we work this time from the most proximal, we look at the nail matrix. So this is where the epithelium proximal to the nail root. This is going to contain the dividing cells, which will push the new nail cells towards the free edge or most distal edge of the nail itself. You'll find the nail root, which is going to be found underneath the skin, which you'll not be able to see with the naked eye. Next, you'll have the eponychium, which is where the stratum corneum is going to meet up with the nail itself. So again, that's going to be stratum corneum, not part of the nail itself. The thickest part of the nail will include the lunula, which is the white part of the nail. You see a nice little cross section there. The nail bed is going to be the skin that's going to attach the nail plate to the epidermis. And finally, see the nail body, which is the visible portion of the nail, and the free edge. As it extends past, as you can see, what's called the hyponychium, that is going to secure the nail to the tip, in this case, the fingertip or possibly the toe tip. And as you can see, it also has its own layers of the epidermis, the dermis, and the subcutaneous fat layer. And then deepest, you'll find the phalanx or the finger bone. This one here is a link to Wiley Plus. Again, it's going to show the last 2 slides that we just looked at, both for the nail, the hair, and also the integumentary system. It'll take you through the most important slides, again, most important diagrams for this particular chapter. So it's a nice little review of each of the major components, which will include the layers of the skin, as well as the accessory structures, including the hair, the nail, and also different types of glands. So now we come to our first lecture question for Chapter 5. Most people are aware that the fingernails as well as toenails help protect the fingers and the toes, but also help in grasping objects, sometimes very small objects, or trying to use any kind of fine motor control. But it also does one other very important function. Those of you who have ever injured the fingernails or the toenails before, or hopefully have never lost a fingernail or toenail. Very simply, if you try to put pressure on the anterior side of the fingers or the toes, you'll notice that that particular digit can bend back quite a bit, and oftentimes it can be uncomfortable. The fingernails and toenails actually provide a very important function for sensation. It provides a solid backing to allow both fine and also gross motor touch. So again, fingernails will obviously protect the fingers, also help in grasping objects, but also provide a backing to allow for proper sensation both in fine and gross motor touch. Now, I had a patient of mine before he was actually a full-blown chef, back when he was in culinary school. He slipped and sliced his left thumbnail. Now, the picture I'm going to show you next is not his thumbnail, but it does give us an idea of the concept we're looking at very simply. So in this case, he did slice a portion of his left thumbnail pretty far back into the cuticle and into a certain area in particular. So very simply, the question goes like this. The surrounding nail after he had injured grows normally, but the part of the nail remains split where he cut it and doesn't heal. What has happened to cause this? Now, no, we haven't talked very much about any kind of wound healing as of yet, but obviously there's one area of the nail where we have a lot of mitophagy dividing cells. So very simply, that allows the nail to grow. If that particular nail matrix, in this case, if that's destroyed, that particular part of the nail will not grow back. So very simply, this is what happened with Mr. Nigel, where he sliced his thumbnail so poorly that he actually cut through the cuticle and got into the nail matrix. So in his case, he actually has a split in his nail. So it's very similar, but it's not going to be the same picture you're going to see in the next slide here. So as you see on the picture on the left here, this is a picture of someone who actually injured his or her nail matrix, which is going to be found underneath the cuticle of the skin, or the cuticle of the nail, excuse me. So very simply, what happened is he has two distinct parts of the nail. It's either split by the free edge right through there as it works its way back into the nail plate. Now, it's impossible to tell whether this is a permanent situation here or simply the nail is simply growing back. You can kind of see there's still a little bit of a scar there. If you look more in the lunula, you can see the dark area right through there. So very simply, this could be something where it may eventually grow itself out or may leave a permanent line or scar. As you can see, it's more longitudinal on that particular nail on the left-hand side. Other types of fingernail pathologies, as you can see on the right-hand side, this one is more a horizontal line. This is usually from an impact. Those of you who have caught your finger in a door jamb, a lot of times it has a visible line going through the nail here. This will grow out over time. Oftentimes, if it's hit severely enough, the area underneath the nail bed will become very bruised, become black and blue, and may lose the nail at the same point there as well. Other types of fingernail pathologies, which I'll just talk about briefly, there's one called spoon nail, where very simply, instead of the nail curving down towards the deepest part of the finger or anteriorly, actually scoops upward. So if you were to put a drop of water, you could literally hold a drop of water in a spoon nail without dropping it. Other types of fingernail pathologies, which you may talk about when we get into the respiratory chapters, you get what's called club nail, where very simply the thumb, as well as the fingers, even the toes, may go cyanide or go blue. This is usually a sign of a very severe respiratory issue. It usually means a emergency room intervention. So as we talk about healing of the nails, let's talk about wound healing in general. Very simply, we see two types of wound healing. We see number one is called epidermal wound healing, which very simply, it's only going to be a superficial wound. It only affects the epidermis. This does not get past the basal layer. So in this case, if we get like a relatively superficial cut or superficial burn, very simply, as long as it don't go through the basal membrane and it stays relatively intact, what will happen is if there's any kind of opening or detachment at the stratum basale layer, you'll get a migration of the cells at the stratum basale until they eventually touch. Once they actually touch, a chemical reaction will occur, and they'll start to fill in or just mitophagy divide new cells through the stratum spinosum, into the granulosum, and then out into the lucum if there, and then into the corneal layers. So very simply, you'll see again the stratum basale will start to reform or reattach, and then as it attaches, it will have a chemical signal to start filling in the wounded epidermal area. The other type of wound healing we see is deep wound healing. This is where you're going to have an injury that will extend through the epidermis to the dermis and then possibly into the subcutaneous layer. This is where scar tissue will often form. So very simply, you're going to have one area, you're going to have a dilated blood vessel that will bring in white blood cells that will clean up the area, as well as platelets to try and block off a damaged blood vessel. So you'll get a simultaneous dilation of one blood vessel and a constriction of the damaged blood vessel to try and clot the area and try and prevent any further blood loss. You'll have different types of white blood cells, in particular monocytes. If you have any kind of inflammatory response, you may get neutrophils there too. And what will wind up happening is the fibroblasts will start to secrete more collagen fibers in a very random fashion. And then once that's plugged, you'll have the blood clot start to form in the wound. Then again, you'll have the epithelium at the basal layer will migrate until they touch again and then start to fill the wound. So as you see on the inflammatory stage, you'll see the abundance of the red blood cells, the white blood cells. What you don't see are the platelets. So that'll form a scab or blood clot in the wound. And then once you get into the maturation phase, you'll have scar tissue that'll fill in that hole, which again is usually be dense, irregular tissue. And we'll talk about scars later on and what kind of long-term effects they can have at the same time. But again, eventually the epithelium, the basal layer will start to meet, and then again start mitopically and dividing through the superficial layers, and eventually push the scab off, so it'll flake off eventually. Once the inflammatory phase ends, you start the next phase, which is known as the migratory phase, where the epithelial cells will bridge the gap. You have fibroblasts that will synthesize scar tissue, and the scab forms, therefore plugging the wound. Next, you have granulation, where you start to have the mitopically dividing stratum basale cells start to fill in the epithelial cells. Once that kicks in, you have what's known as the proliferative stage, where the epithelial cells will start to form underneath the scab. That's where you're going to get that nice, healthy pink tissue underneath the scab itself. Finally, once there is enough epithelial tissue underneath the scab, it'll mature and then the scab will slough off. So anytime you have any kind of process or any kind of formation of scar tissue, it is known as a fibrosis. So the fibrosis could be found either any one of three layers, either the epidermis, the dermis, or in the subcutaneous layer. Now, different types of scars, if they stay at the boundary of the wound, it is known as a hypertrophic scar. If it extends beyond the wound, let's say if you get an extension that goes more superficial than the actual layer of the epithelium, is known as a keloid scar. So this is where some people get like a texture scars in particular. For some people, the inflammatory response as well as the migratory and proliferative response goes a little bit into overdrive, and that's where you get the keloid scars. Instead of being a nice flat scar, it tends to be a little bit of overgrowth. That can be somewhat problematic later on because very simply those keloid scars can be uncomfortable, or they can be victims of abrasion, where very simply you keep irritating the keloid scar, it actually can keep growing. As we get into each system, I'll be talking about what embryonic tissue each system will be derived from. Some will be from multiple layers, but in this case, around the fourth week, the epidermis is going to develop directly from the ectoderm. So all the nails, all the hair, and all the skin glands are going to come from epidermal derivatives. Where the epidermis will come from the ectoderm, the dermis will come from the mesoderm. Now, as we age, we may see different signs and symptoms that show us that the integumentary system may be changing. In this case, we may see a person coming in where wrinkles are developing, where dehydration and cracking may occur, which basically means that the collagen and elastin starts to lose its elasticity and also lose its actual structure, so it allows the skin to kind of sag and also allows it to crack. You may also see, especially in the elderly, may see the sweat production will decrease, so they can very simply be more susceptible to things like heat stroke. So naturally, we want to try and keep them somewhat cool, or try and keep them out of the real hot environments. We also see the melanocytes may start to diminish, resulting in gray hair or atypical skin pigmentation, including liver spots. In some cases, though, especially with people's hair where they go white, it's not so much the melanocytes, but in white hair in particular, you start to notice air bubbles. If you look at the actual hairs themselves under a microscope, air bubbles actually will replace the actual melanin found in the hair follicle itself and actually have a white appearance instead of gray. But when we have a decrease in melanocytes, you will start seeing gray hair, which again, that can happen in some patients in their early 20s, or it may not happen until late 70s or 80s. Also, you notice in particular where the elderly may actually be feeling very cold or very chilly, even in the summer months. It's due to the subcutaneous fat being lost, so they don't have that insulative layer anymore. And finally, as we can see as well, just with the skin, you may also notice that the nails themselves may become more brittle as the keratinization of the epidermal cells is not sufficient enough to maintain proper strength on the nails. Also, we see bed ulcers, otherwise known as pressure ulcers or bed sores. So you often find these in the elderly where they have poor circulation. In this case, you can see one right on the heel there. So very simply, you can see it actually eating all the way through the epidermal layer down to the dermal layer. These will lead to permanent scarring in particular. Other segments of the population that are susceptible to this are the diabetic as well as the obese. So the way to circumvent this is we have some patients that will either get massages done by themselves or by other caretakers, or if they're in a hospital, this will be turn the patient back and forth. So very simply, there won't be any undue consistent pressure on certain body parts. You can find these on the heel, you can find these on the buttock, certain areas of the arms, also certain areas of the trunk as well. So next, let's talk about skin cancers. So skin cancers can come from either genetics or from excessive exposure to ultraviolet light. A lot of times from overexposure to the sun without adequate protection, or oftentimes we see this with people that frequent tanning salons because it's a very focused dose of ultraviolet rays. Very simply, the most common type of skin cancer is basal cell carcinoma, also be the least malignant, followed by squamous cell carcinoma and malignant melanoma. Malignant melanoma is the worst, very simply because it can metastasize very easily. Oftentimes can metastasize to the spine or the spinal column, as well as the lungs and or possibly the brain at the same time. So again, in order of severity, BSM is what you want to remember. Basal cell carcinoma is the least malignant, followed by squamous cell and also by malignant melanoma. More often times than not, you will see a dermatologist for this. A lot of times they'll cut the skin cancers out, do a biopsy. They may go back in and do what's called a Mohs surgery, where they actually will scoop out as much of the epidermis and possibly the dermis as well to make sure you get the root of the carcinogenic cells to make sure it doesn't come back. Sometimes you can just do a quick little cut and cryofreeze to basically burn or ice that particular area off, but a lot of times they do need to go a little bit deeper, and oftentimes they'll do some type of bone scan as well to check for a metabolic scan as well to make sure there has been no other metastasis to other parts of the body. Okay, burns are usually graded according to their severity, but burns can come by different types. Think about done by excessive heat, electricity, radioactivity, or oftentimes from different types of corrosive chemicals that can denature or break down the skin cells, in particular break down the proteins in those skin cells. So first degree burn, which most of us have had at least at some point in our lives, only involves the epidermis. Very commonly we see this with sunburn. It can be painful, but it's not a serious problem. But again, it only affects the epidermis. A second degree burn will destroy not only the epidermis, but also get into part of the dermis as well. There's a lot of times where we see blistering. These oftentimes are the most painful out of 3 different types of burns. A third degree burn will burn through all 3 layers of the skin, so through the epidermis to the dermis, all the way down to the subcutaneous layer. It destroys all 3 layers. Now, these are not quite as painful, and very simply the reason why is you've burnt through all the different types of sensory receptors found in the dermis. There's no pain to be felt. There's no sensory receptors to fire off. So even though you cannot feel these are actually the most dangerous because this can lead to dehydration in certain areas. These are usually going to be a hospital intervention where a lot of times they'll keep the area moist or possibly do some kind of skin graft. Usually they come from off the hip or off the thigh to try and repair any kind of third degree burns in those particular areas. Now, aside from first, second, and third degree burns, we also try and quantify how bad a burn is by how much surface area it has affected. So we use what's called the rule of 9s, which is usually mostly for adults or adult victims. We use a slightly different format for kids and also for obese patients. They use a slightly different percentage, but it is somewhat close to the rule of 9s. Very simply, every body part will have a roughly 9% surface area attributed to it, except for the perineum only has 1%. So in this case, when someone comes in as a patient with certain percentage of surface area, is basically going to be using the rule of nines. In this case, the anterior and also the posterior head and neck would be 9%. Both sides of the upper limbs will be 18%. The full anterior and posterior trunk will be 36%. The anterior and posterior thighs, legs, and feet are going to be 36% complete, which will all add up to 100%. What we normally see is the higher percent or higher percentage of surface area that has been affected by the burns, then the lower the rate of possibly surviving that particular type of burn. So you want to see a lowest percentage possible. It usually means that the person will be able to recover, although with scars, will still be able to recover more easily. But the more surface area that's burnt, the more at risk the person is of the injuries being fatal. Now, the next lecture question I want to pose to you is basically based off of a patient actually who still sees me that has a very particular type of mass found in the upper part of the back. So just me being cute, I called it RLQ5, which is real life question number 5. So very simply, this old woman named Sarah came to see me with both cervical and lumbar pain, which means neck and also low back pain. When I examined her, I had her prone on a table. I noticed I was palpating around the right mid-thoracic region a lipoma, which is found measuring roughly 7 centimeters by 5 centimeters by 3 centimeters lateral to the thoracic spine. So again, if you look at the thoracic spine, it's more to the back. You go lateral to the right side, which means it's just lateral to the thoracic spine, so right before you hit the shoulder blade. She reported to me that it's not painful, it's soft and malleable to deep pressure, and is movable under the epidermis. So based on what you know of the integumentary layers, what is the lipoma, and where would you expect to be in the skin, and why? Now normally if we were in class, I would have you look up what a lipoma is and also give you an idea where it usually attaches to. So I'll basically give you the answer here. So a lipoma is very simply a fatty tumor. So where do we find fat in the skin layer? We find it in the subcutaneous layer. So very simply, a lipoma is an overgrowth of adipose tissue or fatty tissue that grows through the dermis, but doesn't quite break through the epidermis, and is somewhat malleable. In other words, you can press it, you can squeeze it, and it's not very painful because, again, there's no nerve endings found in the subcutaneous layer, and it's very freely movable under the epidermis. This is how we differentiate a tumor or a lipoma versus, say, something maybe attached to a muscle or to a bone. If it was attached to the muscle, the person would feel some kind of pressure or some kind of pain as they move the muscle, but it's freely movable underneath the epidermis. So lipoma is going to be a slow-growing, benign tumor of adipose tissue. Usually remains stationary and grows very slowly. They tend to be solitary, they're very soft, they tend to be mobile and somewhat painless. They're usually found in adults over 40 years of age, sometimes in children. More often times than not, the lipoma will stay exactly where it is. Some patients, if they notice it's an area of high friction, let's say it's near the armpit, or let's say it's near the groin area, they may opt to have it either drained and or removed. More often times than not, they'll leave the lipoma exactly where it is. Usually a dermatologist or possibly even a plastic surgeon may be asked to excise the lipoma. So a lipoma can either be uniform or sectioned. Lipoma is what you see on the top slide on the right, where very simply it's one solid piece of adipose tissue, of fat. Occasionally you might have what's called section, where very simply it may be surrounded by other types of tissues. It may be sectioned off by different areas of the dermis, in this case possibly irregular connective tissue, maybe separated by blood vessels. But by feel, by palpation, you really can't tell whether it's uniform section until you actually excise it. So next discussing question. A model is concerned about a new scar on his abdomen. He tells the surgeon that there's practically no scar from the appendix operation he had when he was 16, but he had a gallbladder scar which is termed gross. His appendectomy scar is small and obliquely located on the inferior abdominal surface. By contrast, the gallbladder scar is large and lumpy and runs at right angles to the central axis of the body trunk. Can you explain why the scars are different? So very simply, now this gentleman here, again, this is hypothetical. The appendectomy scar is small and obliquely located in the inferior abdominal surface. So remember we talked about the different planes. Oblique means anything that's going to be diagonal or not at 90 degrees to either the sagittal, the coronal, or the transverse planes. By contrast, he had a gallbladder scar, which you know the gallbladder is on the right side of the body, and it runs at right angles to the central axis of the body trunk. So very simply, it's going to run, if the axis of the body trunk is going to be more mid-sagittal, then his is going to be actually more so in the transverse plane. So this, you can assume, is most likely not arthroscopic. It looks like it was one of the old style scars. So a lot of times what we see in different types of scars, there's a certain body map that we use, in particular for surgeons in particular, which I'll show you in just a quick sec here. We have what's called cleavage or tension lines. So very simply, we have a body map of how the elastin and collagen fibers are oriented all throughout the body. For the most part, most of us have roughly the same map of cleavage or tension lines. And the reason why I show you this is when we're talking about any kind of incision, it's important for the surgeon in particular to try and follow the cleavage or tension lines, because what winds up happening is if we cut along the tension lines, we cut parallel to the tension lines, then very simply those collagen and elastin fibers can actually roll them together and kind of fill in the gap, and therefore it will be a smaller scar and also will heal much more quickly. Now, if we were to cut perpendicular to those cleavage or tension lines, very simply you're snapping the elastin and collagen fibers in particular, so therefore it's going to take a longer time for that to heal. It's going to require more stitches, because very simply that tensile strength you have in the elastin and collagen, when you rip that or you tear it, very simply you're going to have almost like when you snap rubber band, it's going to reverberate back to the periphery of each ends of the fibers, and it's going to have more of an open wound. So most surgeons that know about cleavage and tension lines will try at their best to try and cut along parallel to the cleavage and tension lines to promote healing and also have less of a scar. So next question. A premature infant typically lacks subcutaneous adipose tissue. Typically, the adipose tissue really starts to form within the first couple of months after birth. So with a small body, has a relatively large surface area compared to its volume. How do these factors affect the ability of a premature infant to regulate its body temperature? So first, let's talk about the subcutaneous adipose tissue. We know that it's used as an insulator. It's also used for protection for the baby. Because it's premature, it was born too early, so the small body has a relatively large surface area compared to its volume. In other words, there's not enough surface area to contain the heat from the volume of its body. As we start to grow, the surface area starts to grow more compared to the volume, so we have more adipose tissue to protect or actually insulate all the body heat that we're generating. So those of you who either have kids or possibly have younger brothers or sisters or have taken care of an infant, what's one of the first things that we do when we have an infant to try and keep them warm, to try and regulate the body temperature? Well, there's a couple different things that we use. Number one, we hold the baby close to the body. That's why oftentimes when the baby is first born, they put it on the mother's chest. Body-to-body contact helps maintain body warmth. Another thing to do is what's called swaddling, where you wrap the baby up nice and tight, again to kind of hold all the baby's body temperature close to the body as best possible. And last, if you remember a couple of slides back, we talked about the importance of having hair on top of the head, which helps prevent heat loss from evaporating from the head. So of course, the baby has very little bit of hair on their head, so what we do, we put a cap on them at the same time. So subcutaneous layer is not fully formed until about 34 weeks, and that starts to grow after the first couple of months. If the skin temperature of the baby drops even 1 degree, then baby's oxygen use can increase by 10%. So it puts them more in a pattern of stress, which is not something you want to do for a baby. So we use external heat, such as incubator or skin-to-skin contact, and oftentimes we'll use swaddling and a hat to help circumvent the high surface area to weight ratio. Otherwise, we'll lose too much heat from the head. And here's an example. These are two of my girls. It was taken quite a few years back when my youngest one was born in 2010. You can see she's swaddled. She has a cap on her, and of course my daughter as well as my hands there too. So we're maintaining body heat contact to make sure the baby stays nice and warm. Next lecture question. Josie reassures her mother that the tattoo she received at the tattoo parlor, that's a mistake there from me, will eventually disappear. She knows this because she has learned in biology class that skin cells are shed every 4 weeks. Is she correct? Why or why not? So those of you who have tattoos will probably be able to answer this question a little more easily than most other people. So very simply, when we talked about the epidermis in particular, the epidermis, as we know, has a stratum basale layer that's constantly mitotically dividing and pushing cells towards the periphery or towards the superficial layer. So very simply, we have almost a full or a new set of epithelial cells throughout the skin every 4 to 6 weeks. Now, those of you who have tattoos, where do they inject the dye? They don't inject the dye in the epidermal layer, they inject the dye into the dermal layer. So no matter how many times the epidermal layer will replenish itself, that tattoo is going to stay there. Now again, the tattoo may change in time, very simply because your body may actually attack the dye itself, because it's a foreign substance, so white blood cells may continue to diminish on the actual ink, so it may change over time, but that tattoo for the most part will stay there. So as you know from tattooing, there's a permanent coloration of the skin with a foreign pigment. The ink is injected into the dermis and stays relatively stable. We know the epidermis will shed once every 4 to 6 weeks, so the pigmentation will eventually gradually fade with time, but the lymphatic system will break down the pigment on its own. And that comes to the end of chapter 5. We will do some kind of quiz on the slides therein, so make sure you study not only the nail picture, the hair picture, as well as the slide showing the 3 layers, the epidermis, the dermis, and also subcutaneous layers. You will be asked to identify nerve sensation receptors, as well as different types of accessory structures in that slide as well.